Now I would like to invite Dr. Kim Jung Anh from Kim's Clinic, Hà Nội, Việt Nam, present about the intervention in enthesopathy. Thank you.
Thank you for having me here today. I'm Dr. Kim Jung-eun. I'm a radiologist from South Korea. Currently, I'm working at Kim's Clinic in Hanoi. So today, I'm going to give a presentation about intervention in enthesopathy. So what is enthesopathy? What is enthesis? It means that the insertion of tendons and ligaments into the bone surface. So like you can see picture here, and so this is enthesis, the tendon insertion to bone surface and the ligament as well. And in broad meaning, we can call bursa as enthesis as well. So this is histology of enthesis from the mouse supraspinatus tendon. You can see here, this is bone cortex. This is bone cortex, and this is calcified fibrocartilage layer. And there is tide mark, and this is uncalcified fibrocartilage layer, and this is tendon. And this is going to be the one of the site for injection in the case of enthesitis. Enthesitis is important because the enthesis is the site of stress concentration at the heart and soft tissue function as well. So usually, enthesitis means that inflammation of tendons, ligaments, or joint capsule insertion. It means that inflammation of enthesis. So when we think about enthesitis, we tend to think about spondyloarthritis, including various arthritis like psoriatic arthritis or ankylosing spondylitis or other undifferentiated spondyloarthritis. But today I'm going to focus on the sports-induced enthesis. So this is another picture of, another picture of, I don't know what happened here. Okay, so in the middle, you can see here. This is the difference between. This is because in rheumatoid arthritis, the inflammation usually occurs in the synovium, so we call it synovitis. But in the case of spondyloarthritis or ankylosing arthritis, you can see the inflammation in the enthesis, so we call it enthesitis. And this is enthesis distance from joint. And usually when we talk about the sports injury with enthesitis, this is about this kind of tendons. And we have the name of enthesis here, relevant to sports-induced injury, sports injury enthesitis. Imaging of enthesitis kind of varies according to the phase of enthesitis. At first, you can find a mechanical injury to the tissue, and then it leads to vasodilation, and it goes to enthesis inflammation, and finally, there will be a new bone formation. During this phase, you can see the neovascles and neonerves, and this is going to be the target when we do the injection for enthesitis. This is ultrasound findings for enthesitis. You can see lots of names here, like patella tendon, quadriceps tendon, Achilles tendon, but you can see that all the images are very similar. You can see fibrillary pattern of tendon and the site of the bone contact, so we call it here enthesis. This is the site of injection. Because lateral epicondylitis is one of the most common diseases that we can meet in our daily basis, clinical basis. So today I'm going to give a presentation a little bit about lateral epicondylitis. But once you get familiar with this lateral epicondylitis, you can apply this to all kind of enthesitis. So I think it is a good example when we consider about the enthesis injection. So number A picture, the A picture means that the normal common extensor tendon insertion to lateral epicondyle. Here, this is normal image. And this is a mild thickening of the common extensor tendon. And this is you can see here, there is the prominent spur here. And you can see the hypoechoic within the common extensor tendon. And when you see this kind of focal hypoechoic lesion, this is going to be the target of the injection. And this is a severe thickening of common extensor tendon with increased vascularity. And you can see, sometimes you can see the calcification within the common extensor tendon. And this is the picture that the site of the needle when you do injection for the lateral epicondylitis. So this is the position of the lateral epicondylitis injection. The patient should flex their elbow, and the physician will sit by the patient, and this is the pro position. And this is pro position for the common extensor tendon and vertical image, and this is the pro position for longitudinal image of the common extensor tendon, and this is the example of injection. The needle goes to the from the distal to proximal, and its target is the hypoechoic lesion within the common extensor tendon. And this is another technique for the common extensor tendon injection. We call it peritendinous technique, and I'm gonna talk with you about the peritendinous and intratendinous and enthesis injection. So when we do the intervention for the common extensor tendon or other enthesis, where to inject, there is three types of techniques here. The first one is peritendinous technique. So this is the target is interface between the common extensor tendon and the forearm fascia. So it is the high volume hydrodissection detaching the fascia from the underlying common extensor tendon. And the second one is intratendinous technique. Its target is inside a specific portion of the common extensor tendon, like a hypoechoic lesion on ultrasound. And the third one is enthesis technique. So peritendinous technique, because one of the pathology of the enthesitis is neovessels and neonerves. So our target is to interrupt, to disrupt these vessels and nerve. So if the vessels and nerves from outside, from the superficial to the deep portion of the tendon, we have to disrupt this layer. So this is the aim of the peritendinous injection. We have to locate our needle between the superficial fascia and the tendons. So if you want to make sure that if I am in the correct position, you can just tilt your needle to make sure. So if you can feel any resistance, you can be sure that you are in the right position. But if you feel some resistance or a block when you tilt your needle, it means that you are now inside of the tendon. So it is not the correct position for the peritendinous injection. And the second one is intratendinous injection. It's almost same, but the target is intratendinous, like a partial thickness tear or the intratendinous vessels or nerves. So we have to target this lesion. So which one is more efficient, from distal to proximal or from proximal to distal? Some authors tells us that if you go from distal to proximal, that you can cover less area than the proximal from proximal to distal. You can see that if your needle goes from proximal to distal, you can cover wider area So they recommend when we do the intervention of the lateral epicondylitis, our needle should be from proximal to distal. And the third one is anthesis injection. As I showed you before, there is some specific layer between the bone and the tendon here. And if there is aversion injury here, you can target this area. And with this procedure, you can do some drilling effect. When we see the contral defect on the knee, the surgeon, they do microfracturing surgery to induce the regeneration of the tissue. So it's likewise that we can do some drilling for the bone cortex to make new tissue formation. The second problem is what to inject. There are lots of options. When it comes to the injection agent, injection material, maybe the most common injection is corticosteroid injection, but we have other options like PRP or prolotherapy or even sclerosing therapy. So actually, we have lots of articles here to compare some effects between among all the medicines. But there are lots of articles, so you can see it later. I just want to show you that sometimes we can use hyaluronic acid for the lateral epicondylitis and PLP as well. And even botulinum toxin we can use for the lateral epicondylitis injection. And I think this is a kind of good article, so you can consider. So it says that for the short-term effect, like less than 6 weeks, the corticosteroid is the best choice. And but for the long-term effect, longer than 6 weeks, prolotherapy or PRP or other blood product is superior to the corticosteroid. Because corticosteroid is one of the most common injection material for the enthesitis, I just want to mention about the complications of steroid injection. Maybe you are very familiar with the kind of side effect, but I just want to highlight these two: skin atrophy and the tendon rupture. Because sometimes I meet the patient, not the patient that I treated, but the patient who got the treatment from another hospital. They just complained that after that injection, for the lateral epicondylitis, they had the depigmentation of the skin. So, women, they are very sensitive with their skin, so we have to be careful when we do the steroid injection for the lateral epicondylitis, because common extensed tendon is kind of a superficial structure compared to like a supraspinatus tendon or patella ligament. And sometimes we can see the tendon rupture case after the corticosteroid injection. And as I told you before, once you get familiar with the common extensed tendon lateral epicondylitis, you can apply this kind of concept to all enthesitis. But Achilles tendon and plantar fasciitis is kind of special because they are very close to normal fat pad. So if we use the corticosteroid for this disease, it can be very easily affected from the corticosteroid. And as you know, corticosteroid, it has some effects for atrophic fat pad. So if you want to remove your fat from your belly or thigh, you can use corticosteroid to remove it. But in this case, if you inject the corticosteroid to Achilles tendon or plantar fascia, it can affect normal fat pad in the heel, and atrophic fat pad of heel itself can cause the pain of the heel. So we have to be careful in case of Achilles tendinitis or plantar fasciitis. I think my presentation was kind of basic, but take-home message is that we have to decide what to inject considering patient symptom and affected site or the patient clinical history. And we have to decide where to inject. I would just want to highlight that we need to use our Doppler to see the hypervascularity of the ancestors. Thank you.